still come together and work, and that's it. So the overview, Dr. Aileen, Dr. Lakshmi, would you mind just taking only this slide? Overview. You're muted. You're muted.
Yeah. So I think today's talk would be very useful for the respiratory management of these kids with neuromuscular disorders. And mostly we do see SMAs, and we do see some fair amount of Duchenne muscular dystrophy as well. But most of them who need respiratory support would be SMA1s and SMA2s. And the issues, we would be looking at what would be the actual issues in these neuromuscular disorders, like specifically in SMAs, we have issues like the role of the parents and the difficult airway, and then the modes and what can be used as forms of respiratory support, the interfaces, especially when you take up BiPAP or non-invasive ventilation, and the respiratory issues. Of course, most of them are prone for hypoventilation and sleep issues, and definitely some of the case scenarios, we've actually learned a lot from these kids in the past couple of years, and each case has taught us something which we had not anticipated. So I feel like maybe like 3 years back, we are actually in a better place as to what to expect from these children. And likewise, even our counseling is targeted that way. Many of our kids are on home ventilation, and some of them are actually doing quite well respiratory wise, if I would, when we see them on follow-up. And the way forward, of course, there is a question mark. Of course, there are a lot of issues in India, right from parental denial to the cost issues. And this is not a one-time thing. It's a very, very long-term treatment, and they would require it for a long time. So all these issues are there. And right now we are seeing a lot of community-acquired pneumonia, even in healthy kids. So definitely in children with some kind of neuromuscular disorders, it is going to be much more prolonged, and they would be more susceptible to these common infections as well. So all these things have to be kept in mind. So Dr. Anne and Dr. Aileen, we will go forward and learn a bit more about all these issues.
Hopefully we'll learn together, which is what we've done. We've all learned together and grown as a team. So thank you, Dr. Lakshmi. That was a very good sort of summary of what our journey has been over the last few years.
Exactly,
and I'm hoping others can comment as well. So we are just talking about certain diseases. How have things changed? And some case scenarios, some home ventilation, what is the way forward, as we said. We all know what neuromuscular disorders are. All these places where we're talking about, these are the anterior horn cells and nerves. All of us know all these things. To the motor end plates, to the NMJ junctions, and the muscle itself, and that's what we're talking about today. So we all know they all have weakness. They all have, many of them have cardiac involvement. But even those that we thought do not have cardiac involvement, like SMA, for example, since we are changing natural history, we have personally had 2 children who have had ventricular tachycardia right in front of our eyes, arrested and died. So this is again teaching us that cardiac involvement is not, it's quite fairly described in literature. Many of them tend to have arrhythmia. We just still haven't figured out what is a way forward to monitor them. We do tropies and stuff like that. We do ECGs, but we don't know how frequently. At least in DMD, we know how frequently to monitor. So this is a wait and watch space, and maybe all of us together would be able to come to a consensus so that we can guide the rest of our colleagues. So breathing difficulty, swallowing difficulty, scoliosis, and chronic disease fatigue, weakness leading to respiratory failure, sleep hyperventilation, swallowing problems, dysphagia, aspiration, failure to thrive, aches, pains, cramps, wasting, distorted body image, contractures, and ultimately they look different. They look weird. So people treat them also. People look scared when they look at them. So there is social exclusion. So Dr. Aileen, would you like to take over the slide?
Yes. So these children land up with respiratory failure. They have a considerable amount of upper airway collapse, which worsens, the upper airway resistance. These children also these children also land up with respiratory tract infections, which can lead to lung collapse, atelectasis. And of course, a very poor chest wall compliance. You know, the muscles hold the chest wall together. If the muscle is weak, the chest wall is just so floppy. So recurrent chest infections, they take so long to recover from even a very mild respiratory tract infection, and ultimately chronic respiratory failure in most of these kids. So let's go through DMD, a prototype of many of these neuromuscular diseases.
So one of the things that we would need to go through is all of us were taught in medical school that this is what DMD was. Everybody knows by third year, fourth year, everyone knows what Gowers is. We know the pattern of weakness, the proximal weakness. When it is unchanged natural history, they die by the time they're 14 or 18 in their second decade. Second decade sounds big, but 14 sounds terrible. And this is to date what is happening in our country. Without any supportive care, that's what happens to most children. Now, with the advent of extra care, this is from 2011 from Kate Bushby's team in Newcastle, and this was published in Muscle and Nerve. And this is what steroids did, what preventing scoliosis did, what cardiac management did. And then this is what it did to Becker's as well, because many of the Beckers died of heart failure as well. Now, the same thing, we'll see another slide, which is from Professor Eugenio Mercury's team. So primary cause, as we all know, is because of cardiac involvement. We know 100% of them have cardiac problems, respiratory care, respiratory failure, and spine stabilization and steroids are the single most, they're the two most important things that have changed natural history. Children should not have, DMD children should not have scoliosis. So then that is entirely out of the equation. Then it comes to steroids. So we'd like to actually, it's two cases, compare and contrast. So this is a 3-year-old child who came long ago, was referred to us because of speech delay. We noticed toe walking. CPK we did came down to be 16,800. So this is early diagnosis. We did a dystrophin analysis, MLPA, and of course it showed out that it was positive. He had 45, exon 45 deletion, but they were not compliant. And at 8.5, he comes almost non-eminent. He's about to stop walking. So this is this little boy. You can see him. They're from a village somewhere. He's barely able to walk without support. Whereas, in contrast, is this 13-year-old who has a similar delusion, but he has been taking treatment for 4.5 years. He's on daily steroids. He's still able to sit up and get up. But he's demonstrating good anti-gravity upper limb strength. Dr. Irene, would you mind commenting on this child? The child here on the left, who is very young but had an abnormal sleep study, who could not lift his hand above the shoulder. You're muted.
Yeah, sorry. Most of these kids, there are ways to analyze. There are ways to check for their lung functions. We also do PFTs in them, but PFTs. We have seen that it really undermines the level of issues, and the best way forward is a sleep study. So this child who couldn't lift his shoulders up obviously was already having issues with sleep hyperventilation, not breathing well at night, hypopneas, apneas, and obstruction, versus the other child that Dr. Ann showed that he was still doing pretty well because his disease, he had received the right treatment, the right guidance. So very important to assess that the child not able to lift his hands, the anti-gravity muscles not working, then we know that definitely this is one red flag that we must screen them, or these kids already need to be initiated on BiPAP.
So this is another child who's already another 8-year-old already developing scoliosis. This is a complete no-no. But this child came to us like this at diagnosis. This problem.
Somebody has to mute.
I've muted, ma'am. Can carry on.
Yeah.
Followed by how we're monitoring very closely what's his motor ability, trying to guide it as much as possible so that they reach maximum potential, walk as much as possible. Then once they lose ambulation, the goal is so that they can maintain upper limb function and rest, because that is closely linked to respiratory function. Then we are then looking at nutrition. We don't want them overnourished. Once they become undernourished, we are worried about respiratory, because that would be the reason why they're losing weight. Then we're looking at bone health, because bone health is closely linked to fracture, scoliosis, fracture which would be unnoticed, compressive fracture, scoliosis which will again compress the spine, and or rather it will cause restrictive changes to the lungs. So these are all adding on, everything is adding on. Cardiac function, everything is related. Then of course the psychosocial, they don't feel like doing anything. They don't see a point to it. So all of us here in this forum are familiar with this 2018 guidelines, the standard of care, which is the current guideline, which is due for change mainly because there have been so many disease modifying therapies. So just looking at disease modifying therapies, many of you are aware, we are about to start, there are 5 centers in the country and we're about to start these treatments. Dystrophin not present, your normal skeletal muscle, dystrophic, bad looking skeletal muscle full of fibrosis, reddened, and the fibers that are very eosinophilic that are dying. And here's the extra, the skeletal muscle, which has got very good, surrounding dystrophic protein that is exhibited on immunohistochemistry, and the Duchenne where the immunohistochemistry shows 0 dystrophin. And what you're trying to do with exon dis or exon skipping is that if 49 and 50 of the dystrophin gene exon is missing, you're trying to get the 51 out of the picture by an antisense oligonucleotide, which will bind to it and make sure that 49 binds to 52. So this is given as an intravenous injection, and we're about to start this soon in the next few weeks. So the entire goal of giving antisense oligonucleotide is to restore the reading frame, and these are the approved morpholinos. So the eteplirsen, the golodirsen, the vitolarsen, and the casimersen. But of these, 3 of these molecules are coming to India, and they're starting this month. So technically, all of us know, I think many of us are aware, that 80% of Duchenne muscular dystrophy are eligible for exon skipping. 20 are not. But of this, not all, all these 4 does not cover all of them. So then there is, of course, the stop codon read-through, the atalurin, that when there is a nonsense mutation and the protein is prematurely truncated, what you're trying to do is make sure, ignore the premature truncation, read through it, you're asking it to ignore the nonsense mutation and making the ribosome less sensitive to the stop codon so that a full-length dystrophin is produced. So this was done by PTC Therapeutics, but it is pending approval by FDA. It's approved by EMA and Brazil. So now we are coming to a new natural history. This was presented by Professor Eugenio Mercury and Gemelli et al. And what they are trying to say is that we have lots more work to do, because your 6-minute walk test, your North Star ambulatory, all of them, everything is changing. Your 9-hole peg test, everything, all the patient-reported outcomes, PEDS quality of life, everything in neuro quality of life, everything is changing, not only with steroids, but by giving of these antisense oligonucleotides. So we are in a very strange, challenging era. So now we move on from our world of DMD for the time being to this slightly depressing child. So this is a 2.5-month-old baby. This, I think Dr. Lakshmi is aware of many scenarios like this. I landed in PICU, ventilated for pneumonia. PICU noticed there was a bell-shaped chest, parental consanguinity, and this is what the chest looked like. Parents had been given no history of anything. They kept saying nothing's wrong with the child. So our PICU pediatric team, they already knew what it was. They sent, and lo and behold, they were right in their prediction. The child turned out to have SMA. Then once with the diagnosis, as neurologists, we were asked to go see. We went and saw the child. Child already had contractures. So we offered them, do you want curative care? Do you want palliative care? It's already far too gone. Even if you give it at this point, might not make a lot of help. There's already pulmonary hyperplasia. The parents opted for palliative care. So this is just SMA, one of our SMA children, that's his nasal voice, which is very gurgly. Wow. That's him. He's very weak. He's type 1 SMA, and this is what SMA looks like. All of us know that. And this fasciculation that is demonstrated here. You're all familiar with it. Unfortunately, this baby died. This was a very well-preserved type 1C, but we could not get free medicines for this baby, which is what happens to many of our babies. As you can see, he's just able to open his mouth a little bit. So we're all familiar with this classification of 0, 1A, 1B, 1C2, 3A, 3B, and 4. So this is, pardon me, most of you are very senior, but this is for those who are junior in the group. Just one slide for them. So clinically suspected, once we suspect SMA, because there are potential treatments, we would need to do an MLPA for SMN1 deletion, making sure that you check for both the SMN1 and the SMN2 copy numbers. If there is 0 copy, that confirms 5q SMA. If there is 1 copy and you're still thinking very hard that this is SMA, 5q SMA, then you'd have to think about SMN1 sequencing. And if there's a mutation, then of course you get the diagnosis. If there's no mutation, something else is wrong. You have to look for another diagnosis, another neuromuscular diseases. If there's more than 2 copies, it's not SMA. Unless again, you think it's a consanguineous family with a very weird diagnosis of some point mutation, which is very, very, very rare. So SMN2 is needed because the copies will help us in trying to figure out how to get, how to fit them into disease models or treatment models. So then if they go into this red box of if they're not SMA, what do you do with every other neuromuscular disease? You evaluate them. You try to localize the lesion. That's what people like Dr. Radhika and people would do. EMG, nerve conduction, CPK, and all those things. And you do things like, is it neurogenic pattern? Then are you directly going to go to a whole exome or a whole genome? Or is it a myopathic pattern? Do you want to do more muscle biopsy? Again, we are going very little of muscle biopsies. Now, in the era of disease-modifying therapies, everything is changing. So the answer is there a cure? Many of us are losing patients even after we give them curative, so-called cures. So we know that there is a gene replacement therapy. We know that there are 2 splice site modifiers, but many of them, we lose children if they don't. And so we're going to come to some of those patients whom we almost lost. So standard of care is the key. So this is a little baby. You can see what's happening here. He's a type 2 child who's actually less weak than the baby who died there. But because he got gene therapy, we did everything. So he had BiPAP and he had gastrostomy fundoplication and he's doing very well. So gene therapy made him better, but cannot prevent him from not having pneumonia. So that was what we were thinking. So these are the lessons that we've learned with more than 500 SMA, nearly 1,000 in neuromuscular disorders, actually more than nearly 1,200, 25 gene therapies, 26 Spinraza, 20 risdiplam. And it's great to see this child who's like this. Second week of post-gene therapy, he was sitting, he was not sitting. But the bad side of it is that he had an older brother who was type 2 SMA, who had nothing, who was much young. It was at 5.5 years of age, that child died. Because the parents were not willing to even try for anything. They didn't want BiPAP, they didn't want anything because he was so scared of NG and gastrostomy that, so you can see he's still very weak. When he topples, he's not able to stabilize himself. So the battle is not at all won. I think we've just started the battle. We know what the standards of care are. They're very clearly delineated in the 2018 guidelines. And Dr. Eileen, would you mind taking over this child who's getting oral risdiplam and has type 2 SMA?
Yeah, thank you, Dr. Ann. So we all know the standards of care. This is very clearly mentioned, especially where acute care, rehabilitation. So we have this girl who's a classic, a child who basically is also diagnosed as SMA. She looks very nice and healthy, no cough, no cold, no pneumonias, no aspiration, but she is wheelchair bound and assisted with her mobility. And what we did is we kept pushing the parents for a sleep study, and she'd been following us up and everything. But what we did see that when we did a sleep study, we found out she had so many events. So her AHI was 19 per hour, which is really, really high and totally unacceptable. And even for the parents, it was quite shocking because they didn't expect this kind of sleep study. Subsequent to this, we have started her on BiPAP and she's doing quite well. She's had no major problems, but this is to extend to this is for us to understand that a child that may be seemingly normal may also have hypoventilation and sleep apnea, and so it's very important to screen them.
Sure.
Next
So,
slide.
So yeah.
Yep.
Can you
Yeah,
see
so
the
I'll go very briefly through this sleep and neuromuscular, some case scenarios, and like very briefly, let's go through it. Anne?
Can you see the next slide?
Yeah, I can't see the next slide.
Okay.
So very important to understand this. When we all sleep, okay, normally all of us when we sleep, we have normal muscle, no problem with our muscles, but there is a decreased ventilatory drive. Your central drive goes down, your chemoreceptor sensitivity goes down. Normally, our respiratory muscles, there is some preservation of our diaphragmatic muscles, but our intercostal muscles, they relax. Upper airway muscle tone relaxes, so they are more likely to obstruct. And like some of us, how we snore, that's the exact mechanism. And in the respiratory mechanism, there is some VP mismatch. Airway resistance increases, and there's a decreased functional residual capacity. So it suffices to say, if we as normal people can have all these mechanics in a child who already has a compromised neuromuscular system, either the muscles or the neuromuscular system is not functioning well. So all these things are going to be enhanced, and this is the reason why these children will require non-invasive ventilatory support at night. The next slide.
This is the. Should I go to the next one?
Yeah, sure. So what happens, as I've already told you, these are the changes that happen in neuromuscular and chest wall disorders over and above what normal people have. They're going to have a lot of chest wall stiffness, poor lung volumes, the muscle is so weak, upper airway resistance is high, hypoventilation, most of them, and of course, these chemoreceptor sensitivity is very poor, land up with hypercapnia, hypoxemia, and there are a lot of CNS related changes. When we talk about lung volumes, you already see so many of our SMA kids with a very low volume, bell-shaped chest. So the lung volume is really low. So you can see this balloon, right? If this balloon, a normal lung, goes down to this, what happens? Our tidal volumes are low, clearance is impaired, they're more likely to have hyperventilation because of the low tidal volume, and increased work of breathing, and that you so classically see in neuromuscular diseases. So, as I again mentioned, it's a normal physiological responses that, the sleep related hypoventilation is much more enhanced in these children. And with the weakness of the respiratory muscles, the chest wall muscles, these children are more likely to progress very rapidly to hypoventilation, muscular weakness, land up with recurrent, and they are not able to cope up with all the problems that occur, especially even with mild respiratory tract. Even if it's a mild upper respiratory tract infection, they can lead to severe respiratory failure. The entire dynamics, they also have changes in the REM sleep, hypotonia, atonia, diaphragmatic overload, and this increasing respiratory fatigue result especially during REM sleep, and this can only be picked up very very early during us when we do a full PSG. Remember, all these children also develop a certain amount of kyphoscoliosis. So again, the lung capacity, or it goes into a restrictive lung, and hence this again worsens the ventilatory impairment. The next slide. So, like I said, if we have a respiratory load and we as have a good muscle capacity, the brain says go and breathe, and this entire balance is very well maintained. In children like this, when we are not able to breathe, your muscle capacity is so poor, and let's say you have a respiratory tract infection, they are not able to take this load. So to balance this load with time, with any respiratory tract infection, this is where the role of BiPAP comes in. You are actually supporting the breathing, actually supporting all the hypoventilation, the hypopneas, all the sleep related issues, even some of them, especially during acute crisis, this NIV plays the major role. There is no other way we can support this patients. Next slide, please. So these children can have apneas, hypopneas, hypoventilation, poor decreased sleep time, sleep efficiency is very low, marked sleep fragmentation, frequent sleep arousals, and even REM sleep is completely suppressed, and because of the severe diaphragmatic illness, hypoxemias can develop, and therefore PSG is the gold standard for assessing all these children with neuromuscular symptoms. We also have various ways to measure the carbon dioxide levels, either the transcutaneous, end-tidal, or in some children we also do VBGs to check for the hypoventilation. So in neuromuscular disease, they have a high risk of developing hypoxemia, hypercapnia during sleep. The next slide, please. and most remain undiagnosed despite the high, and even despite of all our efforts, they remain undiagnosed, and it causes a lot of morbidity and mortality in these patients. So we may have some signs and symptoms. We ask, is the child extremely sleepy, complaining of headaches, CO2 retention? Some say difficulty breathing, positional issues with breathing. They also have frequent urination, excessive daytime sleepiness, poor sleep, witness snoring, and apneas. So what can we do? We can check the spirometry, where we have FEV1, FVC indices that shall predict some of these events. Changes in the maximal inspiratory or sniff nasal pressure is very difficult to do it in children. Blood gas abnormalities you can do on blood gas, bicarbonate elevation, and the nighttime testing. Again, the overnight PSG is the most important test. The next slide, please. So we have a 13-year-old girl who is SMA type 2, recurrent pneumonias from 3 years of age, swallowing dysfunction, GERD, hypotonia at 7 months, muscle biopsy shows SMA, genetic analysis did not pick up any SMN mutation. So pneumonia at 3 years again. So this is a child where there was no drugs given at that time. She had a lot of infections, scoliosis, swallowing dysfunction. GRD was showing a GRD on the pH study. Sleep study at 3 years, very, very high AHI indices, carbon dioxide 54, started on BiPAP. Adequate ventilation was achieved, but the child just could not use the BiPAP. Next slide. Admitted for pneumonia at 7 years, started on BiPAP. We had to do a lot of physio, NEBs, but still had respiratory collapse with bradycardia and then had to be intubated. The next slide. So you can see this X-ray, very small chest wall. There are a lot of infiltrates here, some lung collapse on this side. The next slide. Yeah, you can see it's further worsening, the collapse segment. So again, once intubated, they do fantastically well. You don't need very high settings, but this child had to be intubated, extubated 9 times, and a lot of problems, bradycardia, bag mask ventilation, and next slide. So we had to lavage, a lot of secretions, and unable to cough it out, pseudomonas, ventilator-associated pneumonias.
Lipid-laden macrophages.
Yes,
Terrible.
that's a lot of aspirations, and then parents were really resistant to anything. They didn't know, they didn't want to do PEG, Fundo, but we failed all this and we had to do a trach because 2.5 months stay in the ICU, and PEG was done in the same setting, and fundoplication later because of the high risk situation. Next slide, please. So the child was well post tracheostomy, BiPAP of 18/6, tolerating BiPAP breaks, and of course, parents and everybody managed, and BiPAP care and PEG feeding was continued. Next slide. So swallowing was an issue, pneumonia was there, multiple hospital admissions, poor compliance, and of course, this child had extubation failures, right? Next slide. So this is another 11-month-old child, 8 months of age, diagnosed, had aspiration pneumonia, and the child was brought into ICU very sick, but because we could initiate the BiPAP, this child, we averted invasive ventilation, was able to pull out. Next slide. So later we did the sleep study after 2 months, and it showed 117 hypopneas, which were significant, with 7 obstructive apneas. Child now is doing well on BiPAP, and we also had to do NG tubes to PEG feeds, and she's now gaining weight. The coughs and colds have come down, no further hospital admissions. Next slide. So the very important neuromuscular diseases, but that we need to assess: swallowing, just not barium swallow. We need to check for sleep, for cough, and very important that the muscle, as the minute the child already presents with muscle weakness, especially bulbar weaknesses, we need to start talking about sleep studies. We need to check for swallowing dysfunction, airway clearance techniques, talk about tube feedings, PEG feedings, and by the time we have recurrent pneumonias, atelectasis. Previous slide.
Could I interrupt you for a minute, Dr. Allen?
Yeah. Yeah, and I think you can take over like from
No,
here.
no, 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 not take over, but I just want to invite our speakers to, our delegates or people who are participants to ask. What we learned the hard way is that some of the children who are overtly having swallowing difficulties, we do not do barium swallow or any swallowing assessment because they die of pneumonia after that. We've had quite a few incidents where they have done barium swallow without our knowledge because they heard from other patients that we are doing barium swallow. And I remember nightmare patient, one patient where we were having a camp and we said everybody had to come with barium swallow. This patient came from Chennai with a barium swallow, and that image is stamped on my retina. That child's barium swallow shows the entire tracheobronchial tree. And there have been children who had, what do you think? What do we do with that? Does anyone have any comments? What do you think, Dr. Allen? We just assume that they have unsafe swallow. We assume they have GRD.
Yeah.
And
Yes.
walking children have proven to show that they have laryngeal incompetence. Walking SMA.
Yeah, yeah. No, and I think a lot of times, parents also for I have seen for parents force feeding the kids, and also you ask them how much time does it take. He says, one small bowl of mashed food takes 1 hour. Then definitely that swallowing is not normal, right?
Yeah.
So there are ways for us to. It's not every time you can just get a speech therapist and assess swallow, but there will be some red flags. Some parents will say, oh,
So
they're swallowing.
we don't do
It's
that.
better.
We often don't even go there. Many of the
Yeah.
times we just say clinically, that's it. GRD, unsafe swallow, labeled, stamped, no test. Would you agree
Yeah.
that's okay to do? Or
Yes,
aspiration?
definitely. I think if anybody else wants to comment on that, but the cases that we have seen really have been like, like most of them come with very, very poor swallow. So, especially the SMA ones, right? So, I don't think we even go there to, start assessing them. And some of them come with recurrent pneumonia. So, you know that the whole pattern is aspiration.
Yeah, Dr. Eileen, I would just like to add, actually, we have also seen two kids who
Yeah.
actually worsened after the barium swallow and had to be intubated.
Yeah.
SMA2s.
Yeah.
SMA2s. So even that time we were really thinking whether it is worth it, but I don't know, maybe it's difficult to convince the parents that their child has a swallowing dysfunction.
Yeah.
And when they do see a barium swallow, do they or sort of tend to agree, or is it something like that which you have seen?
That we have, I don't know, Dr. Lakshmi, we've not seen barium swallow make anybody agree. But what we have seen now, I think Dr. Ramya can say that as well. With many of our patients, interestingly, for those who come for gene therapy, we just say, sorry, there's no point in giving treatment to your child.
Okay.
Go ahead, do this. And then other families say, you're like this. If you're Tamil speaking, another Tamil speaking family say, head control illa, you need. They will talk to each other and they agree. It's like you talk till you're blue in the face and they don't agree. And in the end, one parent tells another parent and they agree. And the same parent, especially with the gene therapy ones, initially we told them, look, your child is only 6.8 kgs at 22 months. It's terrible. And they're like, no, I am feeding my child. I am doing it very well. So talk to a few other families, done NG feeding 2-3 weeks down there. Now she's coming and asking me when is gastrostomy.
Yeah, I think there was a comment from Dr. Samya that we could do the functional endoscopic evaluation of
But
swallowing.
it's all resources. It's resources.
Yeah. So we are all like, resource stricken, not driven.
Trapped and stricken.
Resource stricken. So
Yeah.
we do, and like I said, the kids that come in so severe and so sick, there's just no time. Like we just have to put an NG tube, start the the BiPAPs, or rescue them out of a very severe respiratory failure. So some of our kids have come
What
in
are
like
we doing FS for? So we do our barium and everything only for those who are somewhat okay. We have to justify after we have lost a few babies after barium swallow. Those we thought were okay. We have been very careful on whom we said, if I'm writing barium swallow, I'm thinking twice. Wait a second, is it okay to do barium swallow? Am I going to get a pneumonia after barium swallow? These are the things that we're thinking about. Okay, shall we go to the next slide, Dr. Aileen?
Yeah.
Please speak, whoever wants to speak.
So basically, so we have already gotten to this point. Yes, a 6-year-old boy, DMT. Sorry, the case 6 is a 12-year-old with DMT, wheelchair bound by 11 years of age, was gaining weight, very poor ejection cardiac function, snoring, restless sleep. A TNA has already been done, complaints of severe headaches, nausea, respiratory distress, or not having ability to breathe off and on. And his PFTs were actually normal. He was also on steroids. So you can see there is something going on. His left his left lingular lobe is collapsed. This side is collapsed. A lot of infiltrates both bilaterally as well, and you can also see the spine. You can see the spine is already going into the scoliosis, the kyphoscoliosis picture. Next slide. So this is a chaotic study. This is a chaotic hypnogram. But just to tell you that all these events that are, you can see stage 1, 2, 3 REM, stage 1, 2, 3 REM. So the blue markers are REM sleep. When you look at the saturations and obstructive events, it's all concentrated during the REM sleep. So it's just to give you a rough idea that REM sleep, when the muscle atonia is the most maximum, even in normal people, all respiratory events are worse. So these kids typically have, this child typically had this. Next slide. So yeah, so to keep it very simple, it's not that simple, I would say, but we have still managed a lot of sleep studies where we use the nasal flows, the microphones for snoring, the abdominal and the thoracic bands, ECG for cardiac monitoring, saturation monitors, and of course a camera that's constantly on, apart from EEG leads and various nasal cannulas for monitoring the carbon dioxide as well as the air, the oxygen, carbon dioxide, as well as the airflow. Next slide. So this boy that we saw who came in with that chest X-ray had 59 obstructive events, obstructive apneas, right? And this is after his tonsils and his adenoids are removed, and about 104 hypopneas, a total 163 events. So very, very severe, very high apnea hypopnea indices. Next slide. So he was initiated on BiPAP, going to school, less symptomatic now. Yeah. So in DMDs, they have really progressive muscular weakness that ultimately involve all the respiratory muscles. Restrictive lung also progresses. Rib cage deformities may also appear. And so they may be having a very normal awake respiratory function, but we see a lot of these kids have very bad sleep, hypercapnia, desaturations, and apneas, hypopneas, especially that, like the case that I showed you. And remember this, the severity of the sleep disordered breathing cannot be predicted even with a normal PFT, like that boy that we saw right now, right? Next slide. So yeah, these are the major events that we see. Fragmented sleep, really frequently having a lot of arousals. REM is poor sleep or a lot of events, and they also have excessive daytime. They feel tired and fatigued all the time, these kids. Next slide.
So this is, can I just mention this?
Yeah.
So this is just to say that there are multiple models. There are people who look at even dynamic MRIs to look at how the intercostal muscles versus the diaphragm moves in different patterns of muscular dystrophies or neuromuscular disorders. So for example, Ulrich has a different pattern. LMNA, Emery Dreyfus has a different pattern. This is a child with LMNA who often look much weaker. They're axially very weak. They may even walk, but they really have, so walking children who have terrible sleep hyperventilation. So this is something for us to know. And this just was brought home to us the other month with a case. This is a pattern that's available on many publications here. So the physiology, as we said, the physiology is based on, is disease specific. So just speaking about, just adding extra to the DMD with the obesity, chronic systemic steroids, with obesity and the poor cough strength that Dr. Aiden was mentioning about, they have the inability to clear airway secretions. And that's the same thing that is added on from before. They have secondary pneumonia. So even if there's one case that would highlight that, even if they get a viral RSV, something else comes after that because they're not able to clear it. So we can never treat them like normal children. So neuromuscular disorders, they can maintain adequate minute ventilation while awake. This is our crux. When upright, but ventilation to be impaired during times of challenge, violence, sleep, supine positioning. Any of these small things can just topple them off their perch of balance. So they do, most patients, we have such a tough time convincing them that they have a problem, that they do not have, that they have lost the respiratory muscle strength to the point that they no longer have an effective cough until they have a respiratory illness, they decompensate, land in a prolonged cough or to pneumonia. We cannot convince any of them. There are very few people who are educated enough, pick it up early and preventatively, preemptively get this. But we're getting there. Having other families helps. So this is your child, Dr. Island, your myotonic dystrophy, your
Ma'am,
undiagnosed LGMD.
Yeah.
ma'am,
So
if I
13
may, just a
Sorry?
second, I have a query, ma'am,
Yeah.
by Dr. Saurav. So he asked, in children with neuromuscular disease on BiPAP, can nasal interface be used instead of oronasal if child is not tolerating?
Yeah. Thank you, Saurav, for that question. Yes, we do struggle a lot with these neuromuscular kids, and the younger kids. Most of them, we are better off with the nasal interface, despite of the leaks. We may have to use increased pressures, but they do quite well. The oronasal interfaces, what we have seen, the older kids tolerated wonderfully. The DMD kids super fantastically. Like I think most of our DMD kids are on oronasal interfaces because they're bigger and they're able to, the whole mass fit is, I think, better, right?
Okay. Ma'am, can I share my experience just if it's allowed?
Yes, please. Yes, please.
Sure.
Actually, ma'am, I got this trouble recently. Had one child with, CMFTD. She was a congenital myopathy, and she is a 15-year-old. So basically, the same that recurrent pneumonias, and ultimately understood the thing and started her own BiPAP. So started with oronasal interface after doing the sleep study and after consultation with our adult thing, but the chest medicine colleagues. But the thing is, ma'am, they strictly advise for this oronasal. But on putting on oronasal, she was at least in the daytime because her CO2s were in the range of 70 to 90 in ABG. So she was not at all. Daytime she was not at all tolerating. Even night also there were a lot of breaks. So I thought, shall I go for the nasal interface? But I was strictly told that no, for these kind of children, you cannot use oronasal. You cannot use nasal. You have to go for oronasal. So that's why I put that question.
Yeah, Saurav, like, so that we are just, I don't think, there are so many kids we fail because of the interface. We're not able to do oronasal, and sometimes, now if you have to bridge between getting the carbon dioxide levels down and getting some form of BiPAP in, I would completely say that even a nasal mask interface is fine, because you may have some air leak, you may have some upper airway collapse, but still it is acceptable than no interface at all, or not able to use the BiPAP. So I would go by that, and I don't think there is anywhere it says that only the nasal interface or only oronasal should be in use. So
That's what,
I would
ma'am. Yeah, actually, thank you, ma'am. Because I think anything is better than nothing. So at least
yes,
we can help
yes,
them.
Yeah,
yes,
yeah.
yes, yes, yes.
Thank you, ma'am.
Dr. Eileen, if I might add something.
Yes, please. Please, Doctor.
Yeah. So, yeah, actually, for one of the SMA infants, we actually tried an oronasal interface because the pneumonia was worsening and we didn't want to
Yes.
intubate. But we
Yes.
faced a lot of issue with the secretions, with the oral
Yeah.
secretion.
Yes.
So, and the child was sort of becoming apneic because of the secretions. So again, we had to
Yeah.
switch back. Actually, we had thought we would try 2 hours of oronasal and then with the nasal interface. But somehow, even for 2 hours, it was a big problem with
Dr.
the
Lakshmi, isn't this
SMA
Satvik
infant.
Nandan? Dr. Lakshmi,
Sorry?
isn't this Satvik Nandan?
Not Satvik. This was Jason.
Okay.
Jason.
But then Jason then ended up with a tracheostomy. No,
Yeah,
why
that was
I'm trying
later.
to say is
This was
he was
before
very
that.
sick.
Yes.
He was very sick.
This was before that, when they had not agreed for the tracheostomy, and somehow
So
they didn't want to intubate.
This brings out a really important point. The point
Yes.
is, we have a large cohort. Those of them who can be managed by NIV, this is a good one. Those who are too sick for NIV and need invasive ventilation, that's a different ball game altogether.
No, that time we got away. We got away without intubating, and we could even discharge him.
He was in hospital.
But then he ended up sick later.
Yeah.
So, but here we actually tried oral. Actually, it was working. But the thing is, the oral secretions were too much, and somehow the child was suddenly he would desaturate because of the secretions, pooling of
He
the
had
secretions.
apneas. I remember him being brought in just like that. Sudden.
Yeah.
That was
Yeah.
that was
Yeah.
that was
We
that
thought
was
that was Ramya and you who managed to salvage him.
yeah. No, that admission actually he got away without
I
intubating.
remember. Just
Yeah,
like that. 1 hour later, he was fine.
correct.
1 hour
So
later.
he had actually tried the oronasal interface as well
Yeah.
at that
Yeah.
time, but somehow for SMA it didn't work because they would just choke on the secretions.
Yeah,
Again,
they can't handle the
Yeah.
secretions at all.
yeah.
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 Yes,
It
yes.
depends on how bad their swallowing is, isn't it?
Yeah, it was, I think, for that child, but still Dr. Eileen had told us, let us try, because you can give a higher pressure with the oronasal interface, but somehow that it we couldn't
Yeah.
even manage even for 10-15 minutes.
Yeah.
So
Yeah.
of the 300 odd children who are on BiPAP, and of the 500 children who are on SMA, many who are on ventilated, only 10 of them are on invasive. So
Yes,
that
Yeah.
means we managed to succeed with the others.
yes.
So we didn't do such a bad job.
Yeah.
Okay, sure.
Ma'am, in this context, sorry,
Yeah.
Sorry,
ma'am,
please go ahead.
one more question, that in this context, the children who are not able to handle this secretions, and there's a lot of pooling, and we how to take care of these secretions apart from, I mean, the usual techniques what we do.
Well, I think most of our kids, these type of kids, we are anyway putting an NG tube or a OG tube, and very rarely, and sometimes we need medicines like glycopyrrolate in very minimal doses. I think Dr. Lakshmi, you would also like agree with that.
Yeah, yes, Dr. Eileen.
Glycopyrrolate. So
Yeah,
these are
very,
short.
Glycopyrrolate
very,
actually works.
yeah, very rarely. Yeah,
Very small doses.
yeah, yeah.
Okay, ma'am,
It
how
gets
long
thickened,
can it be
isn't it?
used? Only it is an acute phase, or we can use it because I mean, he's so bad swallowing that his own salivary secretions are a problem for him.
Yeah. So
So
he would
how to
ultimately require
take
a
care of that?
tracheostomy in
Yeah,
that
tracheostomy
case.
is the answer.
But it takes a lot of effort to make the parents understand and counsel them and other things. So as a stopgap kind of arrangement for some time to manage the
So,
secretions,
Dr.
maybe for some time, I think maybe it can be used, Dr. Eileen.
Yes, yes, yes. So
We
very, I think we just have few very few patients that once or twice we've given glycopyrrolate.
Yeah.
The rest, we also teach the patients how to do suctioning. The parents, right? Oral nasal secretions, all the suctioning is taught. And of course, those who can't handle it all, they're going to aspirate on their saliva. So they are candidates to be trached, and then make sure that airway is secure. And of course, with the NG tube or a OG tube, that so.
There's a good comment by Dr. Samia Razvi saying that glycopyrrolate can be used longer. Yeah, that is true. You can use nebulized glycopyrrolate, but the thing is it an acute thing or not? You've got an acute sudden RSV infection, and secretion is only because of that. But even after coming out of the acute infection, you're still bad. Then you need a gastrofundo plus or minus tracheostomy, isn't it?
But what I think Dr. Lakshmi, Dr. Ann, all of us, the team that has been handling so much now, so many cases, I think there were just one or two cases that the secretions we had to give glycopyrrolate for a few days. There's nobody on it for long term also.
So shall we go to this one, Dr. Ainan? Yes, we have to go through it quickly so that we finish our talk.
Yes, 13-year-old brought to our ER, distress, carbon dioxide was 68. She had to be intubated, and you can see there's a very severe of steel rod, titanium rods have been put. Her lung looks restrictive, and we intubated. Then again, have extubation failure, but somehow we managed to get the BiPAP in. She was already having, she has already been operated. But in the past history, the parents say that they never had a diagnosis. She was just told some muscular dystrophy problem, unable to climb stairs, frequently fell. And the next slide. Yeah. So, yeah. So her sleep studies again show 73 hypopneas, and of course she was a candidate for BiPAP. Next slide, please. So in her case, we did a titration study, and so the first night was without the BiPAP, and the first half, and then the second half we took her to the titration. And the next slide, we'll just skip this. So basically, she had a lot of hypopneas, desaturations down to 74. Her apnea hypopnea indices were 11.8. And finally, we were able to titrate in the sleep lab at 17/7. That was the BiPAP pressures. Next slide. I'll skip this. And so why do we need this BiPAP? Obviously, we're talking about survival in a disease like SMA or even DMD, where we have now medications that we can help them. We are enhancing the quality of life as well as survival, helping them to deal with all the respiratory issues, the normalized gas exchange, preventing all the things that we can prevent, provided we pick them up early, help some of these kids for improved daytime functioning. I have kids who are on BiPAP, like day before yesterday we had our SMA day, and this 20-year-old boy who's now he even said, after BiPAP my life has changed. So that's a big thing, right? And also to promote growth, development.
And he's
Yeah.
going to college.
Yeah, he's going to college, and he says he's an Android app developer. He's doing BCA. So that's our DMD, a wheelchair bound. They're from Hassan. But he says the 1.5 year of BiPAP changed his life. So I'm going to make a video on him and show you all. Okay, apart from that, respiratory, we can go on to the next slide. Next slide. So we have fantastic interfaces. Every one of these interfaces is available in India now. Okay, so we can't complain. Like this nasal. Okay, so these are just BiPAP devices. All of you are familiar with now. Next. So every device, every kind of mask is available in India, and yes, most of it we have tried it. A word about oxygen, that we have had so many incidents in the past that children with neuromuscular diseases are brought in with, some of them brought in very sick, severe, carbon dioxide level very, very high. So the most important is, don't start giving oxygen. You're just going to cut off their drive, and then the hypercapnia worsens. So most important, support the ventilation with the BiPAP, and then add the oxygen. So we have about 410 studies done. I mean, we could be a little bit erroneous data here because not meticulously counted it. 370 patients of neuromuscular, out of which 112 are SMA. DMDs are about 70. But I think, Anne, you will be saying, you and I know that I think the clinic has more than 1,500 patients now, right? Total neuromuscular.
Yeah, and
More than
and more,
400.
nearly 80% of them have been funded, isn't it?
Yeah, 80% funded with everything from BiPAP to cough assist to everything possible. And home mechanical ventilation is about 400, more than 400. 300 for sure is just neuromuscular, 22 invasive, out of which 10 are SMA patients. And yeah, fantastic follow up, because now we have the video consults and, the ORDI team helping us to coordinate all this. Yeah, next slide. So yeah, to put it, I think, and we can skip this, and then you can take over after that.
Okay.
Yeah, we can skip this. Yeah.
So yeah, we've already gone through all of this.
All this is a
So this is
repetition.
the cough assist. I'm just going through the cough assist. Would you like to go through the cough assist? Some of you are probably
Yeah,
familiar with this.
Settings of -30 for exhalation, +30 for inspiration, and now I'm going to show a demonstration on the child.
So this is a child who received gene therapy who's getting cough assist.
That's not a doll.
That's not a doll. No, it's one of our tiny puny children who refused to do NG feeding and has now done gastrostomy fundo.
Yeah, so most of our kids can be easily trained. We have now a therapist just doing the cough assist on video consult and teaching our all the kids on cough assist. I think currently we have 9 kids who have their own cough assist and 2 cough assists in the system that rotates, and we are able to think. And Baptist team has a cough assist, and Dr. Lakshmi, you can very well let us know how effective or how good it has been for all our neuromuscular kids.
Yeah, thanks, Dr. Adin. Actually, cough assist in the sicker kids, what we have found is initially it is when they're hypoxemic, it is quite difficult because they'll desaturate once the BiPAP is removed or disconnected. But once they start to stabilize and they come out of the hypoxemic respiratory failure, then we have found that it's pretty useful. So the clearance of the pneumonias is faster, and in general, they do tend to tolerate also pretty well. So
So
that
may
has
I
been
add my
our
perspective, Dr.
experience. And sorry, I
May
didn't
I
get
add
that,
my
Doctor.
perspective?
Sorry.
May I add my perspective?
Sure, sure. And especially in the ward when they are, not so sick, then also it sort of helps. So they tend to tolerate it pretty well.
The whole point is to try to shorten hospitalization, prevent ICU admission. That's the function of cough assist. Would you agree on that?
Yeah.
As you rightly said, not acute illness, not
Yeah.
very, very bad.
Not acute illness. They
Yeah.
don't tolerate it very well. They desaturate quite a bit. So
Meaning you have to have a threshold for it.
yeah. The other device, like this is the Respironics one. The other one, the Liam one. So that we thought it was pretty useful even when the child was sick, because it is inbuilt into that, Dr. Eileen.
Yeah.
Yes.
Yeah.
So
Yeah.
we have the Liam.
So-
It is a ventilator with a
Yeah.
cough assist, and the cough assist can be used manually or on auto. But all of us, if we're using, so it's a ventilator with a cough assist. So it's a really high-end device. It's expensive as well, but I think we have two kids on it, Jason and
Ayansh Dubey.
Ayansh Dubey. Yeah, there are two kids that rescued out post-trach, post-gene therapy, and had a lot of issues. But that device really helped because it has an inbuilt cough assist, BiPAP with a ventilator with a cough assist. Yeah.
Yeah. So, and we can just set it, and it just does its job even when the child is asleep, and so that way. But yeah, like you said, it's quite high end, 5 lakhs or so, isn't it, Dr. Eileen? That
Yeah.
one.
It's about 4.5 lakhs.
4.5.
Maybe we should ask next.
Yeah, no, we found that was, much more better tolerated rather when, in sick kids, I think maybe that might be more useful. We'll have to see.
So coming from quaternary medicine to something that's not so quaternary. So
Yes.
this is a child that I was called in. There's a little girl. I was called in the middle of the night from one of the medical colleges that I cover, saying that, doctor, this is not a patient you cover, but a 9.5-year-old who was born with arthrogryposis multiplex congenita. CPK was high, day 11. She slowly started getting better and was walking, but with a lot of support. And so the parents were told that she had a congenital muscular dystrophy of sorts, possibly Ulrich, with the biopsy. And so she just was sent away, and they thought, scientific medicine had no hope for them, and they went away. Now, this child had gone for Kattu therapy. They're from Bangalore, but they went for Kattu therapy somewhere in Tamil Nadu. And there the child was being given Kattu therapy. She became drowsy, and a local hospital tried to revive her because she was having respiratory distress. She didn't get better. She got worse. Transferred to our hospital, to the PICU in one of the hospitals that I cover. And I got this call, and I said, okay, stop oxygen. What is her CO2? So CO2 on admission, her CO2 was 82. Within a few hours of giving her BiPAP, it was difficult getting her sorting the BiPAP out and everything. She just sat up and she was able to be awake. She could sit with support and things like that. So from drowsy encephalopathic state, she drastically improved. So the story was, they were aggressively stretching her. She was crying. She cried, blew out carbon dioxide, and became drowsy. So this was somebody, Ulrich, this is classical. They have diaphragmatic weakness. They're walking, and then she landed like this. So whole thing would have been prayer, and the parents were feeling so bad that they didn't understand, that they didn't avail themselves of respiratory care for this child. So even though we do not have any treatment as such for Ulrich, we could prevent her from dying. So this is a 9-year-old with a respiratory distress, which occasionally happens. She could not be weaned off the ventilator, had distal weakness, was areflexic, and diaphragm showed eventuation, distal weakness. So diaphragmatic paralysis was there. So this is somebody with SMARD. There was consanguinity. There was premature birth as well. Many of them end up with premature birth. They have low birth weight. They have IUGR, feeding difficulties. Sometimes they have dysautonomia and cardiac arrhythmias. So they have this distal fat pads. So the mean age of presentation is around 3.5 months of age, but sometimes it can be 6 months. They can be milder. So we've seen a couple of children. So this is another child.
Ma'am,
Diaphragmatic weakness was the presenting symptom here. So phrenic neuropathy. Secondary to just presented with diaphragmatic weakness. So we've just written all the differentials of those that can present. I think our adult colleagues who are here, I think those from ASTA and other places, they would have more experience, and Dr. Sumant would have more experience. CIDP or myasthenia can present. Late onset Pompe, they're wandering around with a diaphragmatic weakness and respiratory failure, not realizing they have a disease, then fall sick, acutely sick, and then you do and see, wait a second, this isn't just respiratory illness, but there is an underlying overlay of respiratory weakness to it. And then you get the diagnosis and you reach the diagnosis that way. So these are some of the specific morbidities in NMD that we've already gone through. So DMD is especially the pattern that is seen is obstructive initially, because they have airway obstruction. They have tonsils that are hypertrophied. They have thick necks and all those things. FSHD, facial scapulohumeral disease, they have a particularly flat shape in their volume loop. SMART has got diaphragmatic weakness. So this we're ending with some of our SMA patients. So this is a child with SMA. She's now 5 years of age. She escaped with her life mainly without therapy, only through gastrostomy, fundoplication, and BiPAP. She luckily then, and she was fortunate enough to then get Spinraza. After that, she's improving. And this father keeps telling us, please tell whom I should speak to. I will go convince them about gastrostomy. I will go convince them about fundoplication and BiPAP. So she used to get very, very recurrent multiple chest infections a year. So this is a
move on to the next thing. Yeah. Can we just take 2 questions?
Okay, sure.
Sure. To any of the panelists, what is the dose of nebulized glycopyrrolate and how frequently can it be used? This is a question from Dr. Sarao.
Dr. Aileen?
Dr. Aileen, Dr. Lakshmi.
I think Dr. Samya has to answer that question. I have no experience with nebulized glycopyrrolate. Dr. Samya, can you enlighten us?
I have seen Dr. Sujata and team use it. Dr. Lakshmi, do you use nebulized glycopyrrolate?
No, Dr. Ann, we are not using nebulized glycopyrrolate. Maybe it would be good to know whether there's any other medication available, or it is just the IV one which is supposed to be nebulized.
Yes, yes.
So she's written as saying dose is 0.01 milligrams.
But is it the same IV preparation which is supposed to be nebulized?
Approximately. Is it the same IV preparation? Yeah, same IV preparation is what she said.
We could try that actually then. Maybe it would reduce the systemic side effects a little bit.
So the answer, Dr. Saurav, the answer is in this another question that I'm going to say. The same child, Dr. Saurav, the same child who was so sick, this girl,
yes,
after getting Spinraza, after 2 doses of Spinraza, she ended up with an RSV pneumonia, RSV bronchiolitis. She got better, recovered from the pneumonia, and was discharged. On the day of discharge, after going from a good hospital, she collapsed with fatigue, blocking of secretions. We didn't have PICU beds. And what we did was we said, okay, let's just try, before shifting out to another hospital, we just tried BiPAP. She was not sick enough, like Dr. Lakshmi said. She was not sick enough. We just bronchodilated her, gave her cough assist enough. And by 12 hours, she was ready to be shifted out of ICU. And by 2 days, she was discharged out. So that is what a cough assist does. Nothing else can save you from that. The cough assist has its place. Your BiPAP has its place. Your invasive ventilation has its place. Tracheostomy has its place. There's nothing other than cough assist that can do that. Once you use this, you run. There are so many patients who have then come back and said, oh, this is so useful. They understand the value of it. So I don't know what else to say to that. So this is a 4-year-old child who's again SMA type 1 like the other child, got Spinraza, but the family would not accept the fact that this child has got unsafe swallow, is failing to thrive, needed BiPAP. They came with a cold and they kept thinking it was a cold. They kept saying, just cold, not going away. And we kept saying, no, it's not a cold. He's not clearing his respiratory secretions. And ultimately, he landed in Baptist after us really coercing them. They had gone to a pediatrician. They'd given oral antibiotics. Didn't work. Failing to thrive, sleep hyperventilation. So ultimately, what happened was respiratory distress showed this really bad infiltrates. We thought he was going to be intubated. He needed BiPAP. He was so sick, we could not do cough assist. From this case, we couldn't do cough assist initially. So we had to stabilize him on BiPAP because he had been hyperventilating chronically. 24 hours, we gave him just BiPAP. Then after that, we started doing cough assist and then he came out. So both are there. These are all on your armamentarium. So, but we were able to manage him without intubation. So IV antibiotics was there. Now he's getting a gastrofundo. So these are just some of our children who just 4 weeks post gene therapy. This is just, having head control. This is a type 1 child who's having head control. As you can see, the father's just supporting him. And the same child 4 months down the line, nicely turning. And this is 10 months down the line, sitting. This is type 1 SMA, sitting. And so this is Dr. Island. Would you like to go through this paper? This is a poster that was presented. Dr. Island? We are ending with this. Dr. Island? Dr. Island?
Ma'am, she is, I think, rejoining.
Sorry,
okay.
sorry. I'm there.
Okay.
Sorry. Yeah. So basically, this is a study. This is a paper that we presented at the King's Pediatric Respiratory Conference, where we spoke about the number of children that we have had who have been on therapy, and the risdiplam, the Spinraza, and the Zolgensma, and all the children that we had done sleep study on. So it's an entire paper that was presented there, and also we also highlighted the improvement in these kids that are already on the home ventilation. So I don't know whether and is there any way you can enlarge it a little bit?
Yeah, so enlarge it a little bit. I don't know how to enlarge that.
Yeah, I mean, I don't know whether it's visible to you all.
Is that better?
Yeah, I think it's a little bit better. Yeah. So basically, we took about the night. Basically, we have looked at neuromuscular diseases. 92 kids here, and children. The treatment, I think, right? And where's the treatment
This
part?
is a smaller cohort. This is not the entire cohort.
Yeah, this is not the full cohort, but we had, okay, let's do just the conclusion, just do this, that 88% of children were initiated on home ventilation here, and it was BiPAP. SMA1, SMA2, DMD, the most common, obviously earlier, the SMA1s required the home ventilation earlier, followed by SMA2 and the DMDs. And 89% of these kids had reduction in the recurrent respiratory tract infections, and also 66% reported subjective improvement in sleep, as well as fantastic improvement in the weight gain. And so this is just a neuromuscular data that we had presented.
This is just summarizing everything that you.
Yeah, putting it all together.
And this is the last child to end. So this is a non-genetic. Everything we've spoken about is genetic. So this is a child who's currently stuck in our ICU. 3-year-old, 7-month-old child, sudden weakness, pooling of secretions, lost her airway, became quadriplegic. And this is her X-ray, which is showing right hemidiaphragm completely eventrated, paralyzed, phrenic nerve paralyzed. And this is her terrible cord, which is completely swollen. She has a long segment transverse myelitis with AMAN. So we are struggling through the same thing. She's got a tracheostomy. She's slowly responding, but from a chronic respiratory perspective, ventilation perspective, we are struggling with her. She's slowly improving. Her diaphragm weakness is better, but it's still the same principles. So take-home messages. Dr. Lakshmi, would you like to do the take-home messages?
Sure, Dr. Anna. So I think we've come a long way from when we were residents. When I was a resident, actually, junior resident, the moment we say SMA, it would be like sort of palliative care. We would not shift the child to ICU, and we would never ventilate this child. And now I think with disease-modifying therapy, the whole equation has changed. So I think we need to get up for that and see how we can help these children lead a more a good quality, have a good quality of life, actually. And since they're being increasingly becoming treatable, we need to recognize this early respiratory involvement. Actually, this was something new for us also. The sleep studies and the abnormalities in the sleep studies, and We have actually seen children who have been neglected up to 6 years, 5 years, 6 years, SMA2s, and we have seen the contractures and the scoliosis and the failure to thrive in them. And on the other hand, we have seen children who have been picked up early and they have been counseled for this BiPAP and gastrostomy and fundoplication. And when the nutrition is optimized, the respiration is optimized, and they seem to do better. This, we have something which we have actually seen in our practice. So I think this is something where we need to work together and have a multidisciplinary team and see what we can do best for these children. So that is what I would like to say. And complications, we need to anticipate complications and manage them. I mean, with the existing resources, of course, like Saurabh was saying, like we may not have a cough assist device. So we have managed children even without a cough assist device also. It's just that the hospital stay might be a little longer. So we'll have to do whatever is possible. Yeah.
But we can fight for it.
Yes, yes. So we'll have to do
for our cough
whatever.
assist.
Yes. We'll have to do whatever is possible in the setup in which we work in. So I think that is what I would like to say. And definitely, I think we can make a difference in the quality of life.
So this is our final slide, this is from Sunday, our event on Sunday, where it was a nice feel-good event where everybody was there. So any comments from anybody else who's dealing with all these patients? Any of our speakers? Dr. Ramya, please allow everybody to speak.
Sure, ma'am.
Okay, anyone? Anything? Nothing? And shall we say bye and happy Ganesha Habba to everybody? Overshot the time anyway.
Thank you, Dr. Lakshmi. Thank you, Anne, Ramya, and thank you.
So one thing, I don't know if Dr. Radhika is still there. Dr. Ramya, is Dr. Radhika still there?
Yeah.
Thank you.
Yeah, I'm here, Anne. I'm here.
So, Dr. Radhika, would you like to comment? Because normally it's always something in EMG. We usually use the EMG for diaphragmatic weakness and everything. Would you like to comment anything?
So I suppose EMG is to look for any element causes, especially if you're considering diaphragmatic pacing for your central hypoventilation or your UMN causes like the transverse myelitis that you had described before. You just need to make sure that the phrenic nerve is working and there's no active denervation in the diaphragm so that you can pace, for example. I mean, that's usually what I tend to get called for.
Okay, sure. I'm hoping we can do. So our what should our next topic be? We had thought neuropathy. Is that okay with everybody? This is sorry, Dr. Lakshmi. This is a predominantly neuromuscular audience.
No problem.
Is neuropathy okay with everybody? Because we finished muscle, we finished neuromuscular. Is neuropathy okay? Dr. Umesh and other people? Dr. Davidson? Yeah, yes, he said yes. Dr. Davidson has said yes. And then Dr. Radhika would have something fantastic after that. She's got Muni coming up, so she'll show off all her new gadgets.
Not really. Old gadgets trying to do new things. I was just thinking for neuropathy, if anybody has any cases of their own,
you could add it and you could present that. Whoever wants to do that.
We could discuss those cases as well.
Some of our adult colleagues are better with neuropathy than we are. Pediatric people are. Okay, so then we'll keep it as neuropathy. So we see you next last Tuesday of September.
And can I make a comment?
Yes, please. Yes, sir.
Yeah, hi. I was
hi, Dr. Lakshmi and
Dr. Listening to the whole lecture. It's a brilliant arrangement. I and Lakshmi, we are Lakshmi from this end, I mean. So the lady
they're saying hi to us from Birmingham. Yeah, hi.
So, yeah. So
Oh,
I
hi.
think, yeah, hi to everyone. So it's really eye-opening for us. I think we are yet to get started here. I think we are going to get involved in the neuromuscular studies in our department. And the neuropathy, we run a neurology forum program, which happens 3 times a year. I was about to give a lecture on neuropathy actually. So it will be good. I may share some cases I had. I think particularly on the neurophysiology findings, it would be really helpful to hear from our neurophysiology colleagues there. So yeah, hopefully we'll be able to attend next time. So
Okay, so Dr. Murugan, I think you have some cases as well, isn't it? Neuropathy.
yeah, that's what I said.
Yeah. So that would be great.
But like I think it's kind of, if there are time permits, I'll show.
No, we'll do it together. We'll add something. We'll add. Each one does something.
Understanding the neurophysiology part of it.
Yeah. You could work with Dr. Radhika, and it would be great. And if you have we'd have a template. We'll keep it ready. We'll keep our cases in advance ready. So if say Dr. Renu also said that Dr. Renu is from PGI. Hi, Dr. Renu. It would be great if you have some cases you could do. Or I know for a fact that Dr. Menon also. Hi, Dr. Renu.
It was very fantastic presentation, and I'm overwhelmed by your experience with respiratory care. It was absolutely amazing. I can vouch that it's so difficult to put type 1 SMA on ventilation and with cough assist device, and it is such a long journey. I think we have to take what I've learned from today's presentation. Absolutely good learning experience. We do have some cases of CMTs. If you want, we can also contribute.
It would be great if you say you take one case, Dr. Murugan takes one case, and then somebody else from Master takes one case.
Right. That will be perfect.
Sure. And then we prepare beforehand. So it's going to be the 4th Tuesday. Beforehand, and we send it. Just only a few slides. And then we collate it with our 2 resident neurophysiologists are going to be Dr. Bhuvana Rajendran and Dr. Radhika Manohar, so that they can comment on it as well. Then it'll be useful then, because then we can learn. We know some neurophysiology, but they know more than we do.
Right.
So
you just let me know the dates and all beforehand. We'll decide the cases.
Yeah, it's always going to be the last Tuesday. So it will be next last Tuesday will be 27th.
September, right?
Yeah, right. September 27th.
That's great.
Okay, great. Okay, bye-bye, everybody. Happy Ganesh to everyone.
Yeah, happy Ganesh Chaturthi to everyone. Thank you so much.
I hope I have not missed out on anybody else, senior anyone around. Dr. Sundari, Dr. Joshi, Dr. Mukul. Dr. Mukul, welcome. Anybody else? Anyone wants to say anything? Dr. Saurabh Jain, Dr. Sajida?
Yeah, thank you, ma'am. It was a great learning experience for us, especially because now we have started and we're just facing the problems what we had. So that's why I asked those these questions and just got valid, about this. Actually, I was not getting the link, so I just messaged Eileen ma'am, and thankfully she replied very fast, so could attend. It was a great learning experience. Would like to attend more.
What do you work as?
I've done finished my pediatric pulmonology fellowship recently, and I was based in Bangalore. I was a senior assistant in St. John's, and now have joined as an assistant professor in St. John's.
So this is a neuromuscular meeting. Only today happened to be respiratory. So Dr. Lakshmi and all of that are not a part of this normally. Today they are the main focus, and so Dr. Eileen as well. So this is primarily neuromuscular. But yes, feel free to join us anytime.
Yeah, sure, ma'am. Thank you very much.
Sometimes it'll be boring for you. Neuropathy pattern of respiratory failure might be boring for you.
Okay, but this was definitely interesting.
Sure. Thank you. Bye-bye.
Thank you. Good night.
Thank you, Dr. Lakshmi. Long day on a Sunday, on a festival day. Bye-bye.
No problem. Thank you, Dr. Ann.
Bye.
Thank you, ma'am.
Bye, everyone.
Thank you.
Okay, Dr. Ramya, I think that went on reasonably well. No?